Thank you very much for the kind introduction. I was asked to try to speak about polycystic ovary in 30 minutes, which is very, very difficult, but we'll try to get at least to the main points of polycystic ovary. We all have been using Rotterdam criterion, which is 2 out of 3, oligoanovulation, hyperandrogenism, or polycystic ovary. And for adolescent girls, it's usually it's a must to have the 3 of them. So 2 out of 3 does not apply to adolescent girls. A couple of years ago, new EFRE guidelines, and this guidelines actually didn't change much. They spoke about the regular cycles depending on the age, biochemical hyperandrogenism, and they had a length of discussion about the difficulty in measuring the hyperandrogenism chemically, and for that they said that clinical hyperandrogenism is enough. Ultrasound criterion has changed much because now to diagnose polycystic ovary with ultrasound, you have to use an 8 megahertz vaginal probe. Otherwise, only the volume is criteria. A-match is not yet incorporated in the diagnosis, and they focus more actually on the long-term problems of polycystic ovary. That's obesity, diabetes mellitus, sleep apnea, body image, lifestyle modifications, and psychological and psychosexual problems. This was the main things that came with the new EFRE criteria. One more thing about the ultrasound consideration, what we are using, most of us are using, is 2D real-time to count the follicles. And in a very recent study, it was found that what we are doing actually overdiagnose the 2D real-time, the number of follicles per ovary. We usually overestimate the follicles between 3 to 9 follicles, owing to overcounting. Systematic bias was not detected if we use grid overlay. The new modalities like SONO, semi-automated volume calculation, actually underestimate the volume, the number of follicles between 3 and 5 follicles. There are other modalities like multi-planar view with real-time tomography. All this method, except the multi-planar view, took less time to complete the number compared to do a 2D grid. So we have to remember that what we are counting by 2D is overestimation of the number of follicles. This is an example of the semi-automated one, which you just allow the machine to take the pictures, and then it counts automatically the number of follicles present. Between 4 to 5% of white women or 3.4% of African women have polycystic ovary according to these criteria. However, for us, 75% can have a picture of polycystic ovary. And we have here to differentiate between polycystic morphology and polycystic ovarian disease or syndrome. The importance, as we said, the immediate problems, women have a higher risk of diabetes, coronary heart disease, cardiovascular syndrome, the syndrome X, and on the long term, unopposed estrogen, increased risk of endometrial cancer. These metabolic disturbances of polycystic ovarian syndrome are major predictor of prediabetes, diabetes in reproductive age women. And these patients are important clinical subset. Not all PCOS phenotypes have a similar metabolic risks, and those who have this metabolic risk usually have higher neck circumference, which is fairly new idea. So what's the pathophysiology of polycystic ovary? Usually increased weight gain, insulin action defect, which is accompanied by receptor defect, will lead to increase in insulin, and this is accompanied by sex hormone binding globulin decreasing and insulin growth factor binding protein decreasing, which leads to increased free estradiol, at the same time will increase free testosterone, which leads to hirsutism and atresia of the follicles. This in turn will induce increase in LH and decrease in FSH, and the increased LH will act on fecal cells together with the insulin and insulin factor, insulin growth factor, which leads to increased androstenedione, which increases estrone, and this will work actually to increase free testosterone, leading to the same effects. At the end of the day, this unopposed action of estrogen will lead to a higher incidence of endometrial cancer. So this, in short, is the pathophysiology in obese women. So what's the treatment algorithm? We have to remember that these patients don't need to go into their ideal weight. It's a title job to get a patient to lose 40 or 50 kilograms. But what we need is a loss of 10 to 15%. If a patient is 100 kilos, all her problems, the majority of them regarding the polycystic ovary, if she loses 10 to 15 kilograms, is going to be solved. And we treat the symptom, what the patient is complaining of. If a young girl is coming, regular cycles, regular bleeding, the best thing is to give her oral contraceptive pills. If she's complaining of hirsutism, then again, understand the oral contraceptive or testosterone antagonist, or we can give her spironolactone. If the patient is complaining of infertility, the main treatment is induction of ovulation. If we are looking for the general health, we have to combine metformin if the patient is having insulin resistance. We are going to concentrate on what can we do in polycystic ovary in infertility. What are the investigations we need? First thing is to exclude male, because this is going to shift all the treatment we are thinking about. Baseline investigation from my practice, I usually measure AMH, FSH, LH, prolactin, TSH, estrogen, and dehydroepiandrosterone acetate. And I measure insulin resistance in obese women, not for all women, and baseline vaginal ultrasound is a must, and if there is any other factor, we have to assess it. Why is literature so confusing about polycystic ovary? First, because polycystic changes are normal in adolescent girls, so we can't really say that this is abnormal. Polycystic ovarian morphology or polycystic ovary differs from polycystic ovarian syndrome. Polycystic ovary differs from multicystic ovary. Polycystic syndrome behaves differently in obese and non-obese patients, and we have just said, listened to Professor Calvari speaking about that. They are totally different patients, different categories, different etiology, and even different response. And actually, ethnic differences might contribute to different results. Some of you might have seen patients coming from Yemen or Saudi Arabia. Their PCO is totally different from our PCO. Stimulation protocol profoundly affect the quality and results of the treatment. So we have to start thinking about polycystic ovary as not a single disease we are speaking about. It's totally different in different categories. The difference between polycystic ovary and multicystic ovary, they both are bilateral and they have multiple cysts. However, the multicystic ovaries, the cysts are usually larger in diameter, but the main difference lies in the stroma. Polycystic ovary have a very thick stroma. Occasionally, it can be almost like a solid mass, and there are follicles all around. While multicystic ovary have a very thin stroma, these patients usually are in danger of ovarian failure if you do cauterization. So you have to differentiate between the two before you start planning your treatment. Generally speaking, PCO divides into obese PCO and lean PCO, and there is a third category which not a lot of people are aware of, which is burned out PCO, and this was again mentioned in the previous talk when we spoke about resistant patients with polycystic ovary. So in obese patients, these are patients who have insulin resistance, hyperinsulinemia. That's the typical pathway we spoke about. However, in non-obese patients, the main pathology is increase in LH and in growth hormone, which act on theca cells, which again will lead to insulin growth factor 1 effect. And there is a contribution of the genetic predisposition in this. So if you have a family, you can find usually the sisters and the mothers, most of them have this problem. What about the third category, which is the burned out PCO? Polycystic ovarian syndrome is not a static condition. It was discovered at least in non-obese PCO. More rapid androgen decline happens with age. So at the time when AMH decreases and androgen decrease, AMH will decrease, but not proportionately so. The ovarian tissue receptors from younger years are used to abnormally high androgen level. This relative hypoandrogenemia is therefore even more pronounced in non-PCOS patients. Patients with burned out ovary have a very high FSH. It's usually not 7, 8, it's about 14. That's 1.5 times the average height. They have a regular cycle. Usually they are diagnosed with eminent ovarian failure. And when you look at the ovary, you find it's polycystic, resistant to treatment. If you give whatever dose of FSH, because they have FSH, which is higher, they don't usually respond. The only diagnostic criteria for this syndrome is high FSH and high AMH. You find the AMH in the range of 5 and the low dihydroepiandrosterone. Treatment in these cases is usually androgen. If you give it for 6 to 12 weeks, these patients will start to ovulate and respond again to your stimulation. What are the measures of treatment outcomes? Is it ovulation rate or pregnancy rate, miscarriage rate, multiple pregnancy rate, or ovarian hyperstimulation rate? I would say it's mono or having a normal pregnancy in a singleton. This should be our aim in treatment of these patients. So we need to induce ovulation that ends in pregnancy, minimize the incidence of miscarriage, prevent multiple gestation, and obviously minimize the risk of ovarian hyperstimulation. We have too many modalities, whether it's medical treatment with gonadotropins, GnRH analogs, and if we have hyperinsulinemia, insulin sensitizers, and surgical treatment, the old wedge resection, and electrocauterization or laparoscopic or electrocauterization. If we are going to start treatment, we usually start with oral medication. One point here that oral medication should not be prescribed without a very tedious monitoring of the cycle. Though rare, but there is instance of multiple pregnancy and a rarer instance of hyperstimulation. So every cycle of induction should be monitored. Otherwise, the patient is going to keep using it. And there is no point of giving the patients more than 6 cycles of oral treatment if she is ovulating. After that, the pregnancy rate is going to come stationary, or even there is no pregnancy that will warrant the continuation of treatment. Letrozole gives better cumulative pregnancy rate and gives better live birth rates. Gonadotropin treatment, should we use HMG or urinary or RAC with or without agonists? And what are the modalities of treatment in this case? Conventional, chronic low dose, or step down? We have to remember that 2/3 of triplet or high order pregnancy are due to gonadotropin therapy. And obviously, we all know that this is going to increase the perinatal mortality rate, increased incidence of obstetric complication, major emotional, domestic, and financial burden on the family. There is no point of induction ovulation to have a patient being pregnant in 4 babies and aborting at 20 weeks. Well, concomitant GnH, RH improve results. Many of the doctors try to get down LH by giving a longer therapy of GnH, RH, or giving oral contraceptives. It doesn't. It should not be recommended as a standard treatment for patients with polycystic ovary. REC versus urinary, obviously REC is purified, more batch-to-batch consistency. It has a shorter treatment period, as we have just heard. My main point actually in using it is easier to titrate. I titrate very much the dose, giving incrementation in 12.5 and 37.5, and this is much easier for me using the REC FSH. Difference regarding pregnancy rate is questionable. The protocol to use, we need to get monofollicular induction. And the only protocol that gives you this results is the chronic low dose. We give 75 units for 14 days, and we start increasing by 37.5 international units every week. And treatment can take up to 28 days. So before starting, you have to tell your patient she's going to take the medication for almost up to 28 days. And this will give you, in 90% of cases, just 1 follicle, and that's what you need to induce the patient with. Step down, starting with 150 and then getting down 0.5 amp, or starting with 1 amp and increasing the dose, then decreasing. Usually you end with this. Multiple follicles. If you have this during induction, you have 2 options, either to cancel the cycle or transfer it into IVF. And maybe this would be your best option to have reasonable number of follicles. But the stimulation protocol for induction of ovulation, I think for monofollicular, the chronic low dose is the best. Metformin, a few years back, all women were having metformin, and we start speaking about it. There's no advantage over clomiphene in the rate of live birth, and only 1 trial demonstrated the advantage pregnancy rate of metformin use. Use of metformin as initial infertility treatment for women with polycystic ovarian syndrome is not supported by randomized trial. This doesn't mean that patients who have proven insulin resistance shouldn't have it, or the effect of metformin during IVF cycles to decrease the number of small or moderate-sized oocytes. Surgical treatment, laparoscopic drilling, thanks God, I think it's decreasing now. The pros is it has a comparable induction rate to clomistrate. The incidence of multiple pregnancy is less. However, the problem is its operative interference. There is adhesion formation. Ovarian volume should be more than 10 millimeter. Over-drilling can lead to ovarian failure. Everybody of us has seen that. So actually, I don't think for a patient who is responding by any way, we should subject her to ovarian drilling. What about ART? ART, there is absolute indication in patients with a male factor or concomitant indication, tubal endometriosis or whatever, she's going to have ART. After failure of conventional induction. Failure here doesn't mean ovulation failure. It means she doesn't get pregnant. How long should we go on that? I think 6 cycles of conventional oral therapy, 3 cycles of induction are more than enough. After that, I think one should think about ART. What procedure? What's the induction protocol? Should we use IVF or ICSI, IVM or in vitro maturation? What about the results of that? Number of oocytes produced is higher on these patients. Usually we have more oocytes in patients with polycystic ovary. However, the quality are usually inferior. These patients have a higher incidence of ovarian hyperstimulation. It's very difficult to adjust the dose to get the optimal number, which is between 11 and 15 oocytes. It's very, very difficult. Occasionally, half an ampoule will get you to hyperstimulation range, and half an ampoule will get you no response. The main advantage is controlling the number of embryos transfers. Hence, we can reduce the number of high-order pregnancy. Should we supplement? It should be supplemented with a good freezing program, because a lot of these patients will need to freeze their embryos. Should we use agonists or antagonists? They have comparable pregnancy rate. There is lower incidence of antagonist, of hyperstimulation antagonist protocol. If agonist is used for trigger, there is a lower implantation rate. So either we freeze all or we add 1500 units with the agonist when we stimulate. So induction protocol in polycystic ovary, all patients should start with 150 units, no more, regardless of their age or BMI. Antagonist protocol is the protocol. You are not allowed to use agonist protocol in polycystic ovary now, otherwise you're going to get yourself into trouble. I usually see most of my patients on day 8 of stimulation, except the PCO patients. PCO patients should be seen after 5 days of stimulation, and the dose should be adjusted accordingly. Doses increment should be in the form in the dose of 37.5 international unit. And you can see the patient today, increase the dose and see her tomorrow. It takes at least 2 to 3 days to get the effect you want. And follow up after 48 hours. The aim is to have between 10 to 15 oocytes. If hyperstimulation is suspected, agonist is used for hypermaturation, and freeze-all policy should be liberal. Agonist protocol, we usually start day 2, and after 5 days, if you are using fixed protocol, you give your antagonist. If you are working with a flexible protocol, I usually go with the flexible. Once you have a follicle that reaches 13, 14 millimeter, you start your cetrotide, and if you have follicle 17, 18 millimeter, you trigger, and then you decide whether to freeze or transfer. The problem is when you see a patient in the late follicular phase having 18 follicles in diameter above 11 millimeter. The intermediate follicles are the source of the problem. It's not the big follicles. It's the intermediate follicles which gives you problem. Estrogen above 5,000 You can either decrease the dose of gonadotropins or coasting. I don't like coasting. It doesn't work in my hand. But if you are going to do coasting, there are two conditions. First, your oocytes should not be less than 14 millimeters. Otherwise, they are going all to endometriosis. The second thing, coasting should not be go on for more than 3 days. Or early trigger. Instead of waiting for the whole cohort, you can go early a little bit. And the best solution is to cancel and start in smaller dose. You'll never regret a patient's you didn't do, but you can easily regret a patient if she goes into hyperstimulation. On the trigger day, if you have E2 in the range of 4,000 to 6,000, and you have 13 to 17 follicles, either in agonist, if you were actually didn't see it, you can give half the usual dose. There are no studies about the effective dose of HCG, except one study that was done years ago by Hussam Abdullah, and the dose was 2,500 to 3,000. If you are going to give a dose, usually it's between 3,500 to 5,000, and consider cancellation. Even at that day, you should consider cancellation. If it's antagonist cycle, you can do agonist trigger and see the patient 48 hours later. If the patient is okay, you can either modify your luteal phase support or give intense luteal phase support, or you can even start giving her a smaller dose of HCG. So once we have this agonist trigger, a lot of paper came stating that ovarian hyperstimulation free clinic, and you can avoid it by using the agonist. And after a few months, then severe ovarian hyperstimulation syndrome after agonist trigger and freeze all approach. So even with agonist trigger, you can have severe hyperstimulation. It's far less, but still there. Should we use EFRE or IVF in patients with polycystic ovary? This was one of the studies that was done quite a long time ago. There was no fertilization failure in the group of oocytes inseminated by EFRE, whereas in the group that used IVF, there was 9 patients, that's 15% inseminated by IVF in polycystic ovary. However, once fertilization occurs, there is no difference. So if you are going to use IVF, you should at least give half and half or sibling oocytes. What is the results of IVF in polycystic ovary? The presence of polycystic morphology alone in ovulatory women did not adversely affect IVF or EFRE outcome in first cycle. So the patients who is having polycystic morphology, there is no effect. Actually, they do very well. There is no difference in pregnancy rate in polycystic ovarian syndrome between patients and those who have tubal factors. However, we usually in polycystic ovary have extra embryos, and this will give us a more cumulative live birth rate in ART. Speaking about cost effective, there was a paper a couple of years ago, I think, that stated that ART is or should be the first line of treatment in polycystic ovary, cost effective wise. But of course, this is pure mathematics. There are some studies, I think 1 or 2, there was increased incidence in abortion-related polycystic ovarian syndrome, but not with the polycystic ovarian morphology. There are a lot of explanation of this observation, but it's just isolated studies. So, Mr. Chairman, in conclusion, metformin should not be routinely recommended. Patients die from the gastrointestinal symptoms. Treatment should start with clomiphene citrate or letrozole. and should not be more than 6 cycles. Racafasach is easier to calibrate and administer. Chronic low dose is the preferable treatment to produce monofollicular ovulation. Counseling regarding the long-term possible complication, diabetes, chronic heart disease is very, very, very important. These patients, usually the best time to counsel them when they are coming for infertility. Lifestyle modification is a mandatory component of IVF treatment. Antagonist protocol is the safest protocol in IVF. Agonist trigger with liberal freeze-all, if hyperstimulation is likely, should be done. Thank you very much.